We participated in a phase 2 study that evaluated the biological combination of Romidepsin and Lenalidomide for patients with untreated peripheral T-cell lymphoma. It's a phase 2 study, multicenter. It was led by Dr. Barbara Pro at Northwestern Cancer Center. The participating sites, in addition to Northwestern, included Cornell and City of Hope. So we're very pleased to be part of this study and happy to share with our findings at the ASCO meeting. So this study recruited patients with untreated peripheral T-cell lymphoma. And as you know, there's a lot of unmet needs for treating peripheral T-cell lymphoma. Certainly, peripheral T-cell lymphoma, it's an aggressive disease, and oftentimes they have resistant outcome, in response to conventional chemotherapy, in addition to certainly toxicity. So this type of problem could be further exacerbated by the patient population, especially for those patients who were elderly, for example, and who have a lot of comorbidities, who may not be able to tolerate traditional chemotherapy or not advisable for them to have those side effects without adequate therapeutic benefit. So this study was designed to looking at the overall response rate. That's a primary endpoint of the combination of Romidepsin plus Lenalidomide. The secondary endpoint included the survivals, duration response, safety, which is very important, and delay to chemotherapy. This study was based on a previous result from a phase 1 study with dose expansion that also looked at the combination of Romidepsin plus Lenalidomide. In that phase 1 study, which was conducted in patients with relapsed refractory peripheral T-cell lymphoma, the maximum tolerated dose for those agents were Romidepsin 14 milligram per meter square and Lenalidomide 25 milligram. So that formed some of those feasibility base for this current phase 2 study, which now extended into the frontline setting, and particularly in consideration for those patients who may not be chemotherapy candidates. So the study started with Romidepsin at 10 milligram per meter square weekly for 3 weeks, and then Lenalidomide 25 milligram daily for 3 weeks out of a 28-day cycle. And for those patients who tolerate the treatment, after cycle 1, they have the option to dose escalate Romidepsin to the maximum 14 milligram per meter square. So this study recruited 29 patients. 20 of them were evaluable for a response. This group of patients actually looked to be quite high risk. They were quite elderly. The median age was 75 years. And the majority of them, I think 90%, had stage 3-4 disease. And equally high proportion had elevated LDH, which is a marker for disease activity. About 2/3 of those patients had angioimmunoblastic T-cell lymphoma, and about a third had peripheral T-cell lymphoma. So we're quite pleased to report that the overall response rate of all the evaluable patients were 75%, and about 30% were able to achieve complete remission based on the Chesson criteria. We also looked at subtype of those patients, and those in the angioimmunoblastic T-cell lymphoma subtype appeared to have slightly higher overall response rate at 84%. Clearly, it's a small study and provides only a signal for further evaluation in a larger population. I also want to point out that the side effects of this combination appears to be quite as expected, and in large part can be managed with supportive care in the outpatient setting. They included myelosuppression, anemia, thrombocytopenia, neutropenia, and non-hematological side effects such as electrolytes abnormality, low albumin, and infections that can be treated with antimicrobial treatment. So I think it's encouraging because it's a proof of concept that biological combinations can be tolerated, and they can achieve a reasonable high response rates, including complete remissions. So it's really presented treatment options for those patients who could not move on to chemotherapy right away. I think it would be very interesting and important to look at those approaches in frontline settings, whether with the combination of Romidepsin, lenalidomide, and or other agents, to find a better treatment, well-tolerated options for patients with peripheral T-cell lymphoma.